start.
Okay, I think we're starting. Welcome, everybody. My name is Travis Christofferson. We are the title. Everyone hear me all right? Yeah, I got a nod. Okay, so the title of this discussion today is a rational approach to personalized cancer treatments. And we have two wonderful guests. We have Dr. Harry Kuhan and we have Dale Atkinson. Probably many of you know both of these gentlemen. Dale has emerged, sometimes stars align. Dale has emerged through a combination of charisma, humor, intelligence as a rising star in patient advocacy for cancer therapy. And what I want to get out of this is we want to hear Dale's amazing story. And when people are thrust in this world of a new diagnosis, they're shocked and confused. And what Dale offers us is really, he's a wonderful teacher for people on how to navigate this when you're thrust into that situation. And so Dale and Dr. Kuhan was one of the architects on Dale's team to navigate this space. So we're going to hear from both of them today. And I think I'm just going to hand the mic to you, Dale, where you do such a brilliant job of telling your story and what you learned along the way, and then we can go from there.
So first of all, I apologize. I've got a virus at the moment that seems to have made its way into my chest. So I'm a little bit unwell. So I apologize if I stop and start coughing halfway through. I'm sure Harry will pick up the mantle if I do.
Yeah.
So in terms of my story, so let's start back at the beginning. So back just over a year ago, so September time, 2024, I went in fact, sorry, not September time 2024, October 2024. It was on my little boy's first birthday. I went in and had an endoscopy. And unfortunately, as part of that, they identified a 9.2 centimeter esophageal adenocarcinoma. And there were also, unfortunately, lots of metastases. So I had lymph nodes involved. Having looked at my patient notes since, it looks as though there was a secondary on my aorta and that there was also another one on the neck of my pancreas as well. Fast forward just over a year later, and with the help of, especially with Harry and Dr. Amanda King, who's a very gifted naturopath, between the two of them, they have helped me hugely to create my own protocol. And within that, we have managed to essentially disappear my tumours. So I undertook chemotherapy. I did, which one did I do? God, my brain's not working at all this afternoon.
Was it Capox?
Yeah, so it was capecitabine and oxaliplatin. So an IV of a platinum-based chemotherapy agent, and then what's known as 5-FU, an oral version of 5-FU called capecitabine, which I took at home on a daily basis. In between, I combined those with pembrolizumab, which is an ICI, so an immune checkpoint inhibitor, or an immunotherapy, as most people know it. And then fast forward from January, which is where I started taking my off-label meds from Harry, and I combined that with the naturopathic side and a keto-focused vegetarian diet, etc. From January 2025 through to now, my metastases have all disappeared. My main tumour has vanished completely, and I am now in a position where we are waiting for my next scan to find out if I'm NED, which is no evidence of disease, which is the closest that the NHS in the UK will give me to a full remission, essentially. So back when I was diagnosed, they gave me less than 12 months to live. They told me I had an 11.5-month prognosis. They told me that unfortunately the chemotherapy they were initially going to give me was going to likely make me far worse before it made me any better. And they told me that at absolute most, if the chemotherapy and the immunotherapy worked well, that I might have 13 to 14 months. 13.5 months, I think, is officially what they gave me. And yet we're sat here now, 15 months or so later. And I am, other than this flu-y, coldy, virusy thing that's wiping me out, I am better than I've been in a very long time. At which point I will hand over to Harry to explain what his position in my care was. Will I go and cough?
Thank you. I'm so sorry to hear about the man flu. It's a terrible time of year. Obviously, in the UK, in particular, there's a lot of patients, family members, their own family members coming down with stuff. So I'm sorry to hear that, Dale. But yeah,
Cool.
that was a brilliant intro. And Travis, sorry, were you about to say something?
No, this is perfect. I was just going to hand it to you. Yeah. So your methodology and how you approach sort of
Yeah,
cases like that.
thank you so much. So I guess I was just refreshing myself with everything. I guess there are indeed steps to this, right? So I kind of start by typically trying to triangulate three levels of data or layers of data. So genomic alterations, immune signatures, and protein expression. So, for example, you'll notice in such sort of testing, whether it's next gen sequencing testing, whether it's Foundation One or Exacta or Tempus, etc. We'll start by looking for X marks the spot, mutational drivers of the cancer that could maybe be actioned. We could focus some sort of precision medicine ideologies against, for example, in the context of immunotherapies or checkpoint inhibitors, we will look for PDL1 or a CPS score above a certain number, or mismatch repair deficiency or microsatellite instability. And on one initial level, of course, for example, with Dale, and finding there were these markers, these sort of sensitivities identified that opened the door to that conversation, of course, around checkpoint inhibitors, adding that on to, let's be honest, the chemo, which we all regard as a kind of barbaric, archaic, simplistic bunch of killing tools. So there was the introduction of course, these actionable, or work against these actionable abnormalities. In addition, anything else that could be targeted, for example, PTEN deletion, mTOR, mTOR, VEGFR, which I can go into a bit more detail, of course, about, but again, other X marks the spot. So things about the tumor biology that could open again the discussion to adjunctive protocols, add-on protocols, whether they be lifestyle or supplement-based, orthopathically, or of course, off-label medicine-based. And it was a case of them trying to cross-reference those findings against the approved therapies, the off-label interventions, the metabolic vulnerabilities, the patient-specific factors, so biomarkers, comorbidities, lifestyle, worrying about drug interactions. And I guess that was the premise. That is always the premise for me, to kind of look at I guess the multiomics, we call it, I guess, trying to find a marriage of all that information, and often start with a plan theoretically. So Dale will probably, and any of my patients will sort of say, I send a sort of 60-page PowerPoint presentations of myself walking through these in a stepwise manner. So for example, when I talk about P10 loss, well, P10 is it's like a brake pedal in a car, right? So its job is to slow down cell growth and keep things under control. But when it's lost or it's not working properly, the cancer cell kind of loses its brakes. And so that means the cancer cells can receive constant grow signals. They can divide faster than they should, and tumors can become more aggressive. So I mean, P10 loss also activates kind of survival pathways, and it makes cancer cells harder to kill. So again, one thought in my process will be making a list of things that can influence P10 loss. What kind of things? Again, off-label medicine, supplement protocols, mTOR activation. We'll find that a lot, actually, mTOR and VEGF or angiogenesis driving. mTOR is kind of like the growth, is where the tumor growth engine is kind of stuck and it's on. So when it's overactive, the cancer cells can build new material quickly, rapidly, and they can become better again at surviving stress and treatment. So the question then begs, how do we suppress mTOR in a meaningful way? Um, VEGF, so I mentioned this term angiogenesis, reflecting back on the hallmarks of cancer. One of the attributes of cancer is to be able to stimulate blood vessel growth towards itself to ensure its own food supply. It's why in sort of ovarian cancer, maybe some colorectal cancer patients, we use Avastin, bevacizumab, but we often find not all drugs that might have a relevance for one cancer is available for another cancer. So it then begs the question, how do we again use non-oncology options to try and blockade, suppress this ability? So this is what I kind of meant by tumor biology. So I often start with theory, make lists of different things, draw from sensitivity information, with the added layer of the work of Astron, a validation academically of these mutational findings or cell signaling abilities with actual proven non-oncology options, that can help embolden the decision-making process. Because the question we often get asked is, where's the data? Where's the data? There isn't often a randomized controlled trial that proves that taking a bit of metformin is useful in many other ways, et cetera, et cetera, et cetera. So I start by theory. So P10 loss, we think of metformin, berberin, curcumin, genistein, quercetin, VEGF loss, artemisinin, mebendazole. So again, theoretically fine, right? Great place to start. But as we know, the main half of this is about practicality. How do you, in a meaningful way, apply this theoretical knowledge to the individual, which is where Dr. Harry's AI steps in a little bit, right? So that's kind of how I start, with my process. And I guess, with building the strategy, it's often in stages. Okay, there's got to be a kind of a stabilization stage where I'm trying to initially support chemo immunotherapy efficacy. The work Amanda would do, of course, about the microbiome, or doing our best to help the microbiome whilst on a chemo, or how else do we bolster the immunotherapy in a way that doesn't obviously encroach or work against chemotherapy, so complex. We might eventually talk about, of course, and we did, about an integrative kill phase, using integrative therapy such as high dose vitamin C and things that might help induce ferroptosis, such as artemisinin or artesunate, validated by these sensitivities. And with all that going on, there has to be flux, there has to be communication, there has to be oversight, looking at bloods, being flexible enough to adapt to the scenarios. And of course, this monitoring involves not just having an open channel of communication, but looking at bloods, looking at the liver function, looking at the tolerability, looking at the body weight, et cetera, et cetera, et cetera. So a fair number of moving parts, and again, credit to obviously Dale, who is obviously committed to this, not from just an academic level, but embraced so much information that he's just obviously been an inspiration to most of us because of his method, his discipline, and of course willingness to try things.
It's remarkable when you look at the history of medicine. We think of healthcare as sort of this impenetrable tower, right? But when you look back, some of the biggest drivers for it were from patient advocacy. When you look, for 80 years, there was a procedure called the radical mastectomy, where women were given no choice. They were literally put under anesthetic, put on the table, and told nothing. And sometimes they'd wake up with a radical mastectomy, sometimes they'd wake up without one. So they were just passive participants in this process, and they demanded the clinical trial that would compare a simple lumpectomy to a radical mastectomy, which I think it went away in the 80s, but prior to that, some people remember it was absolutely a horrific procedure. Sometimes ribs were removed, collarbones, everything they could get to, basically. And it was, came from this premise that cutting more was better. And to get that clinical trial was brutal. That's a lot of the doctors called the doctors that were participating in it murderers. But the patients drove it, the women drove it, and in the end, it was shown a simple lumpectomy is just as good. And it took 80 years for that to happen. So this idea of patient advocacy, which Dale, you are obviously play such a brilliant role in. What I'm interested in is when you're given this dire prognosis you were given, which alone, when you're sitting there, obviously is shocking. And then you're presented with this the obvious conclusion that standard of care is not good enough. And something that always bothers me is sort of these off-label treatments that Harry's using are pitted as us against them. And I don't see it that way. I see it as complementary. And everybody wants more data. Harry, you just said, where's the data? Where's the data? Everybody would like more data. What you're doing and what Dale is doing is a different calculus. From a patient's lens, when standard of care is not good enough, you're looking at a risk potential reward scenario where we can define the risk, as obviously, Harry, are so careful to do, And then we try to assign a value to a potential reward of some of these adjunctive treatments. So Dale, when you're sitting there and you have this dire prognosis, what was the process of you to start looking? Obviously you had to look elsewhere. How did you, what was your steps in that?
So I think in order to cover my steps, I probably need to cover a little bit more of my story as well. So just prior to my diagnosis, my partner had actually had lung cancer. So in the summer of 2024, she had a funny turn and they thought she'd had a heart attack. So they carted her off to hospital. They ran some tests and they found a nodule in her lung. They found a small tumor in her lung. Fast forward to the beginning of October, it was the 3rd of October, she had a full lobectomy. So she had the upper right lobe of her lung entirely removed in order to sort of to get rid of the cancer, as it were. And then roll on a week and a half later was my diagnosis. And then a week and a half after that, my mother actually died as well. So we were in a position of stress and shock and grief as well. I had a partner who wasn't able to pick up our little boys, and we've got a now 2-year-old and 4-year-old, but at the time they were just under 1 and just under 3. She wasn't able to pick them up. She wasn't able to care for them. And then there was my diagnosis that came on top of it. That then put us in a position of either we roll over and die. I could have very happily turned around and said, okay, just give me the chemo, that's it. Or we fight. And I have always been that sort of a person. I've always been somebody who went, okay, the odds are against me, therefore I'm going to try even harder. And what I did was, the first thing was I sat down and had a look at, first of all, whether there were any alternatives to support chemotherapy. Anything that I could do in order to basically improve my own chances. And with that, I then came across the likes of Jane McClellan's book, How to Starve Your Cancer. And I began to read very heavily. And I read everything from Kelly Turner's Radical Remission through to Jane's book, through to all sorts of things I found. And what I began to piece together was this idea that chemotherapy and the standard of care wasn't the only route, and that there were a lot of things there that can be done in order to support those and to make them more efficacious. So simple things like Harry's already mentioned, metformin. We've already looked at berberine. Adding on top of that, things like intermittent fasting, using prolonged water fasting going into chemotherapy in order to have a neuroprotective and cell protective sort of barrier there as well. And I began to piece together these little bits and pieces all over the place, and I started to test them on myself. I started to do 10-day water fasts. At that point in time, I was unfortunately going into cancer cachexia as well. So I was suffering with malnutrition. My body was essentially starving. And I thought, well, what's the worst that's going to happen? I'm either going to starve myself to death, or I'm going to starve the cancer out a little bit and make things a little bit easier. Now, for me, because of the location of my tumor and the fact that it was blocking my esophagus and therefore stopping food and water going down, and I ended up at the point where, with a 9.2 centimeter tumor in my esophagus, I wasn't able to swallow water very easily for quite some time. So for me, I could feel the difference very, very quickly of some of these things, and I could tell whether they were going to work or not. It took me 2 days of water fasting to realize, okay, I don't feel the pressure I had in my chest quite as much. I can start swallowing water without extreme amounts of pain. And at that point, I'd been having to lie on the floor after every sip of water for about 10-15 minutes in writhing pain. I was on lots of opioids. I was on pregabalin. I was on oxycodone, all these things in order to cope with the pain. And over the course of one singular 10-day water fast, I was able to stop those, because obviously it managed to regress my tumor enough that the pressure wasn't there and the pain was no longer there. So I started to look more and more heavily into these things and bits and pieces, and I began to piece together my own sort of protocol, my own approach. And with that, I got hold of everything from, the standard things that everyone looks at, the ivermectin, the fenbendazoles. I went and had a look at, I got hold of low-dose naltrexone as well, which is an anti-opioid that they use for people coming off of heroin, etc. And it's been shown to have anti-cancer properties. And I began to piece together my own little bits and pieces that I thought might help me. Fast forward another couple of weeks, and once I'd finally been told that I was actually terminal and that there was very little they could do for me and that it was palliative care only, I then began to sort of reach out even further and look for professionals like Harry, who I came across on my journey, in order to try and help me to piece this together and make it something even more effective. The one thing I quite quickly realized at that point was that, as we've already said, that I needed data. I needed something to base this off of. I needed a baseline to start from. I needed something to tell me what specific markers my tumor had, what specific things were going on inside of me, and therefore what drugs would be the most effective against those. And I spoke to, I think it was 31 different either next generation sequencing companies or companies who provided some level of genetic testing or WGS as well, so whole genome sequencing, etc. And I went through 30 plus of these companies globally, and eventually came across Astron, which is why we're here, and decided to utilize Astron in order to basically map out and to give me a roadmap of what was going on inside of me. Fast forward to the output of that. So they used the data genetics test, which Harry then very kindly interpreted and gave me a full outcome for. We also then had the output of the Astron health test itself, which added another layer of bits and pieces on top of that. And it allowed us to sort of create that initial plan of the individual pathways, that my cancer had utilized or was utilizing, and therefore which drugs and which approaches would be the most sort of relevant and efficacious to killing it off and starving it out. With that, very thankfully, I ended up finding that I had MSIH, so microsatellite instability high, which when you're throwing things like immunotherapy into it, have a relatively high sort of success rate, or increases the level of success rate, much like Harry was talking about with the PD-L1 markers, etc. And very thankfully, I was able to work out and piece together the individual bits and pieces to then make that chance I had, because it was only a chance, there is no guarantees in this whatsoever, to make that chance as large as I possibly could. And that's sort of the approach I took, was layering on top, using the data itself and layering in piece by piece by piece. First of all, to see how my body responded to it, and then second of all, to try and work out what the outcome would be of each individual bit layered on top of each other. Because as Harry's already pointed out, with a lot of these drugs, there is no telling how they will interact with each other. There is no telling how the body is going to interact with them. There's no telling how the chemotherapy, the immunotherapy are all going to interact. So a lot of it is trial and error. And I very much used myself as that sort of test subject. Now, I didn't do anything that was crazy. I didn't go taking, methylene blue or horse drugs, etc. I made sure to get hold of and to layer in one by one each individual drug in order to work out whether it worked and to work out whether it caused any damage to me, etc. And I was very careful to try and piece those together and to use professionals like Harry to make sure that I wasn't doing anything dangerous.
Yeah.
So
A 10-day water fast. That's no small task. Did you do the fast right before the chemotherapy?
Apologies, I didn't quite hear that.
Did you do the water fast before chemotherapy intentionally?
Yeah, so I've probably done about 10 to 15 water fasts now, prolonged water fasts of 10 days, between about 7 and 10 days over the course of the last year and a bit. So I did 3 prolonged water fasts before I went into my first round of chemotherapy. So I was diagnosed in the middle of October, and I started chemotherapy in, when was it, late December, early January, I think. Oh God, I can't even remember. My brain's not working very well. End of January, I think I started, or middle of January, I think I started chemotherapy. And in that 2-month period, I was in and out of hospital constantly. And unfortunately, because the NHS in the UK is what it is, they kept trying to feed me cheese sandwiches. And for somebody with an esophageal tumor, I couldn't swallow cheese sandwiches. Therefore, I decided to use it as an excuse to fast, essentially, because I couldn't eat what they were giving me. There wasn't any way to get down anything they were giving me. They weren't paying enough attention to me because I was a palliative case. And therefore, they had people who were much more likely to survive to go and pay attention to. So they sort of left me alone, and I used that time. And I had multiple stints of sort of 8 days, 10 days, 12 days in hospital. And I used that time in order to fast
Wow.
because, well, I couldn't do anything, and what else was I going to do with it?
Yeah. So
I
that's
did.
brilliant. So Harry, tell us, people are probably hearing this and going to 10-day water fast. Why? And so I know you're an expert in metabolic cancer therapy. So tell us the rationale behind the water fasts.
Well, yeah, I mean, look, ultimately it's about priming the body to become as inhospitable an environment for cancer as possible, right? That is the gist of it, right? Just like with everything we talk about from the metabolic approach, I guess, specifically. We are trying to create this hostile environment, make it very difficult for cancer cells to feed, and ultimately, by causing that metabolic imbalance, hopefully sensitize them to being killed with greater effect. There's obviously the talk around, as most of us know, and I'm sure most of the patients will have latched on to fasting before chemo in general. So a lot of patients consider a fast the day before, 2 days before, the day of, the day after, for the same purpose, and often report back. And I had to learn by just asking patients, because you tell a normal doctor this and they'll freak out, right? As I did initially. But actually, no, you don't see a patient collapse into a heap on the floor. They actually reflect back and say, you know what, I tolerated that a lot better than I thought I was going to, or my experience this time round was significantly better than it was before. Now, I think there's a balance to all of this. So again, I'm very biased because I am conventionally trained and I'm very much a case of anti-extremes. We've got inspirational success stories like Dale's and others. There are those who focus on keto, of course, for certain cancer types. As you know, one size doesn't fit all, but there are signals of relevance coming about from obviously preclinical work, let alone from now more and more clinical data. But I think the general gist is ultimately better tolerability of treatment and more enhanced responses to treatment. I mean, like I have a number of patients who do extended fasts. Again, they educate me, right? So again, it's not my go-to to tell patients to do extended fasts. I'm aware of fast mimicking diets, Dr. Valtalongo's work, of course, etc., etc. But I am told by them that, as Dale aptly put together, they are consciously aware of symptomatic improvement. A lump gets smaller, a visible lump gets smaller, or a swallow gets better. But the issue I have, of course, is that my appreciation is that, and this is not what Dale is saying, but anything in isolation doesn't work forever. It is about the combination. And of course, Dale's got a good put together ex-rugby player, right, Dale? He's got, a lot of this stamina, resilience, super healthy beforehand and all of this. But there might be a 70-year-old lady battling cancer who might not have the constitution, not being ageist or anything, but who might not have the constitution to do a prolonged 10-day fast before a treatment, right? So I think the point is here in having this civilized discussion is to not portray people who want to do things as absolutely nuts and crazy, but to be able to empower them by saying certain things. There's a premise behind this scientifically. Everyone's different. If you want to try first doing a fast before a chemo, a day before, a day of, a day after, see how you fare with that. If you want to do something more extended, get under the remit of a nutritionist, talk to Amanda King, whoever else it might be, get some instruction. There's only so far Dr. Harry's knowledge goes, and that's the thing. I think this is why this is lovely to have this talk and discussion. There'll be doctors who might listen to Dale and say, you're going to kill people. I'm sure that's happened in the past, Dale, but actually he's not saying everybody do a 10-day fast. He's explaining his experience and his commitment to trying for himself because the odds were truly against him. And he's portraying that as a signal something important came out of it, right? But as I say, there are patients in different circumstances, which is why the remit of a functional a nutritionist, a cancer nutritionist, unfortunately not an NHS dietitian, unfortunately, a cancer nutritionist is probably important to have these discussions about.
Yeah, it reminds me. Everybody knows the Hippocratic Oath, but there's another saying by Hippocrates that goes back, which was a doctor's opinion matters more than any external measurement. And that ethos carried on. When you read the history of medicine all the way to the first gold standard trial was not conducted until after World War II. So we put so much on doctors as these sovereign entities to making these brutally hard decisions under clouds of uncertainty. And as you just said, Harry, you don't know everything, and so you outsource to Amanda, for example, Nutritionalize. And Atul Gawande, the famous physician here in the U.S., did a great TED talk on this about how we need pit crews now. The amount of data out there is far too complex and too broad for any single individual to incorporate it all. And I think a perfect example of this, Dale, as I listened to another interview with you, and so you were on immunotherapy, and Amanda was talking about how they brought your vitamin D levels back up. And then I learned you were a vegetarian, also doing ketogenic. And so at Astron, what we try to do is find this relevant data that every oncologist should know about when it's important and when it's low risk. And so there's a great study done retrospectively on vitamin D status in immunotherapy. It was over 200 patients, and they look back, and those in the winter months that had deficient vitamin D compared to those that had normal levels or supplemented up to normal levels, the hazard ratios were insane. It was over 100% difference in overall survival. It's vitamin D. Now that knowledge, that data should be in front of every oncologist. Another one is fiber with immunotherapies. 2 studies, and one was at Harvard, and it was a very well-controlled trial that showed the increase in fiber, the response rates are dramatically improved, right? And so these immunotherapies are the new kid on the block, and so much of immune system centers in the gut that we're just constantly learning how to improve their efficacy. And that data, it's diffuse, it's out there, but everybody, it should be in front of, the doctor should know about it. So it's not a small task, sifting through, finding the right professionals. And and so where do you go now, Dale? This has been, are you continuing to, with Extreme, have you sort of graduated to more sort of a maintenance type protocols?
So first of all, I'd just like to point out, Travis, in terms of the finding the team, I think that's probably one of the most important things I did, and it's one of the most important things for any patient, is finding the right team. Now, the team who worked for me, the people who I found the most helpful, might not be the same for everybody else. I found that having a team who I trusted in completely, and I spoke to 10, 20 plus integrative oncologists before I settled on Harry. I spoke to 15, 20 different naturopaths before I settled on Amanda. Finding the right people who speak your language, who talk in a way that you can understand, and who are willing to support you in what you do, is just as important as their knowledge base itself. So for me, I found the right people to support me, who were able to be there, who were able to head in the direction that I wanted to go, and weren't sort of against me or judging me for some of the things I did. And that to me was probably one of the most important steps in this, was getting together that team. And then in terms of what's next, so as it stands, my last scan, which was about 2 months ago now, had some residual disease left. I am not as extreme as I was by any means now. I've been through those kill phases. I've done the high dose vitamin C. I've done the fasting. I've done a lot of the things that I needed to do. I do still have a hyperbaric chamber at home. I do still sauna 3 or 4 times a week. I do still take a slightly different version of off-label meds than what I was. I do still do a low carbohydrate, very polyphenol and anthocyanin heavy diet. But I'm not doing a lot of the things to the same extremes because I don't need to now. Because my disease is now much more manageable and under control, I don't need to put my body through the stresses of throwing absolutely everything at it on a daily basis. Partly because the realization was that if I continued on that route, I would likely cause more damage than I was saving from the cancer. But we have scaled back a lot of things. So I now, instead of doing blood tests every single month and adjusting all my vitamins and throwing loads of things at this, I've tried to scale things back to as low a level as I can, so that it remains stable and so that my disease is slowly sort of melting away, as opposed to disappearing overnight as it was. And that's sort of where I will stick now. So I will continue on my low carb vegetarian high polyphenol diet. I will continue with some of the off labels for many, many years now. I will continue with a lot of my protocol generally for the next couple of years. And I will probably do every 3 to 6 months I will do a prolonged water fast, but 5 days, 5 to 7 days as opposed to 10 days every month. And I will try to twin that in with other metabolic therapies and other things I come across on my journey as well.
Interesting. Yeah, Harry, how do we view this? I mean, because the old view of cancer, clonal in origin, you have to get rid of every single cell. And what Dale just described sounds like more like managing cancer. How do we think about that?
To be honest with you, there are times when I have to speak on the level of what I say to patients is, look, I think the word cure at this point in time is maybe a romanticized term, right? Not to be defeatist. I think a very noble ambition is to control and contain forever, right? So I mean, control and contain, prevent it from breaching a threshold to manifest in symptoms or signs that shorten life or affect quality of life. And the mission is always to get the most durable response from any line of intervention every single time, so that there is a breakthrough, there is a change, there is a movement, there is a feasibly accessible drug, however long that takes. So control, containment, regarding this as a chronic disease, maybe we shouldn't take our foot off the gas pedal after success, but we can fluctuate, ease off, go in, go out, pulse, use whatever terminologies, but essentially treat this as a chronic disease state, a cross to bear for the life.
And it's interesting because I would say you're probably in a more healthy state doing that than when some people would be from when they were before they were diagnosed, right? So this sort of scenario where, like Tom Seyfried has said, is you should come out healthier than when you came in. And when we think about what cancer is, I think if you autopsy most people that have passed, older people that have passed, you're going to find micro tumors. The cancer is most likely within most of us at any time. And how is it remaining in check? And so it's an interesting sort of shifting of theory from trying to kill to extremely healthily trying to manage. And I think that's born from the original days of chemotherapy, right? Where it's you had to kill every single cell, and the way to do that was toxicity, and that's changing. Yeah. So Harry, when you talk about precision, I mean, this has changed, right? From the days of chemotherapy where it was a blunt instrument. And what we knew about cancer back then, the first chemotherapy was ironically a war gas developed in the 1940s, was that cancer was pathological cell division. Now we know so much more, and we're trying to reconcile that. I'm sure for clinicians, we know that it's miswired, right? That the DNA, there's damage, there's epigenetic damage, there's metabolic shifts, right? So how do you, when we talk about precision, do you sort of put it in two boxes? Like you can go after these ubiquitous changes, these metabolic changes. You can also do what we at Astra. And again, we position this as one tool within a clinician's box of tools, where you can go after these mutations. So how do you reconcile those?
I completely agree with what you said. I mean, precision medicine isn't really as simple as you have a mutation, so get me a drug that targets that mutation. We know that doesn't work forever, throughout, we can see throughout recent history. So it's more about personalization, isn't it? So multi-layered plan, genomics, immune biology, pathway analysis, metabolic profiling. Let's go to functional medicine, gut bio, methylation status, heavy metal testing, mold testing. So precision to me, and I think one of the questions on a webinar we did in the past, Travis, was actually, yeah, AI might one day and now allow us to incorporate all of that information and churn out a personalized precision medicine plan. Precision to me means taking into account all of those aspects on a genetic level, epigenetic level, metabolic level, functional level, everything, and using that to titrate a plan for the individual. That's what we want to get to. And having the ability to do so.
Hello, Abigail. All right.
Having the ability to do so, obviously, is it's going to take some time to get to, right? So this is why at the moment it feels a bit broken up, right? Dale driven, and this is why I want this to be an inspiring story to find people, research that it's a lot of time, it's a lot of effort, right? But that is at the moment the only way to facilitate having a uniform, precision, precise model, in terms of going forward. So that's where I'd love us to get to. We're not there yet, but you need a good integrative doctor or specialist. You need a good nutritionist. You need Astron. You need Astron to facilitate doing data and Exacta and the Astron report. You need someone to compile that together. You need, part of this is also communicating, of course, with the conventional team. Not everyone's blessed enough to have an engaging doctor, but again, formally educating them. This is what Astron do. This is the output. This is the conclusion. This is what we have in mind. Can you work with us? And embracing. So cohesiveness, collaborative, efforts again to make the patient journey that little bit easier, because you can probably tell it must be overwhelmingly stressful to try and get all of these moving parts together. But the output after all of that, if it's a success, is truly what I believe is more precision medicine.
Yeah, yeah. Dale, what?
I think there's probably something.
Yeah, go ahead.
I think there's probably something quite important to point out there as well, Harry, in terms of the standard of care oncology side. So I was called stupid by my oncologist. I was called dangerous by my oncologist. I was told that I would kill myself on this route. I was put into a nearly 3-hour-long meeting with my oncologist, with some of the senior nursing staff, with a nutritionist, etc. And I was told my ideas were wacky. I was told it was quack medicine. I was told a lot of these things. And I think the stress that loads on top of actually having to find your team, on top of having to work out where your path is and where you want to combine things and where you don't, it weighs very heavy on patients. And part of what myself and Harry, and I see Justin's on the call as well. So myself and Justin are part of a charity called Beyond the Standard, along with Jane McClelland. And we are hoping to try and push for some change within that world as well. And we're trying to push for more knowledge, more education, and more understanding of the off-label and complementary routes. Not alternative, because this isn't an alternative to standard medicine. It is to complement it. It is to try and make it more efficacious. It is to try and increase the ability of standard medicine. It is not against it. It is not at odds with it. It is not denying chemotherapy works. It is not any of those things. And I think it's important to note that for everyone on the call, is that the two can exist hand in hand, not against each other. And quite often when a mainstream or a standard of care oncologist is saying no or calling it dangerous, it's simply a case of misunderstanding or their lack of knowledge. It doesn't mean that those are actually the case.
That's a brilliant point, Dale. And I think what happens, everybody knows, most people know why, why standard of care is standard of care, that it's presented by a pharmaceutical company, that they're able to fund from drug discovery to phase 3 clinical trials. Now I think it's $1 billion price tag. But no one also questions that it's a gold standard of data, right? We get a big RCT study, randomized controlled trial, and we can see a signal or not. And so standard of care is standard of care. What we then have is this other world of non-patentable drugs, lifestyle interventions that get studied a lot, and there's great studies. When you do a good quality retrospective study, those always get bashed, but the original one on smokers, they're like, well, it's retrospective data. We don't know if it's causing lung cancer. When they did the prospective trial, the doctor's study in the UK, it matched the retrospective study perfectly. And there's clinical trials. There was one on celecoxib. Harry, you probably know about this, for colon cancer. A very safe, anti-inflammatory drug. It was done over 600 academic centers, over 2,000 patients, given adjunctively to, just like you said, Dale, this is adjunctive to standard of care. It was post-surgical for 3 years. And when they did subgroup analysis, the group with a PIK3CA mutation had a 50% increase in survival. That's remarkable. And so the problem within that system is you have that data just gets lost. There's no incentive for doctors to know about it or care, and there's so much of that data. And that's where we get frustrated. And yeah, that's bravo, Dale. That's what we're trying to solve at Astron Health too, is we want relevant data to populate an EMR. Something like the Selicox study, that latest exercise study for colon cancer was remarkable. Again, no risk exercise and very low risk medications. So it's the problem, and I don't know how to address it. And it's just the world we live in. But that's your point, Dale, to patients to not be intimidated by that, to be their own best advocate is critical. And you, when you are in that situation, what else would you say to patients beyond that? How to navigate it? And when you get that, it's an insane moment, I'm sure, when you get the diagnosis. Now you're trying to figure this out. And I know you're a process guy, right? You probably have this. You had more tools than most people. So, what do you think are the points to highlight?
So I think for me personally, there's two things. So I think number one is you need to be your own self-advocate.
Yeah.
And as part of that, you need to begin to at least try and learn and understand your cancer and what drives it. For me, my sort of biggest turning points have all come around my reading and my ability to understand. And it's all good and well going to Harry, and I mean, this is no offense to Harry in any way, shape, or form. It's all good and well going to the likes of a Harry, but if you don't understand what mechanisms Harry is trying to give you, what tools he's trying to give you, and how those interact, you can't then look at your wider, to put it in a naturopathic term, your wider terrain, and then to try and equate for it. So if you are, taking metformin, but you're off eating pizza constantly, you're probably just balancing it back out. It doesn't make any difference. It's not going to help you particularly. And there's a lot of these sorts of things that if you don't understand the mechanisms and what's at play, you can accidentally sort of cut your own legs out, as it were, and put yourself at odds with what you're really trying to do. So for me, number one is the self-advocacy and understanding. And number two is about self-confidence. You have to try and, first of all, trust yourself and believe in yourself. And if you feel that something isn't right, speak up, because I've come across a lot of patients, and I speak to probably 3 or 4 to 5 patients every single day now. And of those, a good half of them lose self-confidence at some point. And with that, they end up giving into things, first of all, that they don't trust or believe in. They end up agreeing to things just because there's a bit of fear to it. So I've come across a lot of patients who've accepted the first chemotherapy they've been offered, despite the fact that it is the most damaging, it's the most this, it's the most that, and they haven't felt naturally comfortable with it. They've wanted to know more information, but they just haven't felt confident enough to ask. And it's also the confidence to say no to things. So not just the chemotherapy, but to say no to a Harry, to say no to an oncologist, to say no to somebody who's trying to push you into something you don't feel comfortable with. And with that confidence also comes the ability to speak up about symptoms, because a lot of us have those niggling little things, like if you start taking a new drug and it starts to give you gut problems, or it starts to cause this or this, a lot of people will swallow it and not say anything at all, because they feel either embarrassed, or they feel unsure, or they feel, well, it's probably just a normal symptom, or everybody feels this. And it's having the confidence to be able to speak up will get you far further than pretty much anything else, than just saying yes to a doctor, definitely. So for me, it's those two things are the most important.
That's a really good point. Just understanding what's going on. I mean, the placebo effect's a real effect, right? And so if you have competence and understanding in what's going on, that's real healthcare. And the team aspect is real healthcare. There's brilliant studies on when people don't feel supported. This one was done in breast cancer, when the women that felt less supported and lonely during their journey had, I think it was a 35% worse outcomes than the women that had teams, care teams, right? So there's these intangible aspects to healthcare that are very, very real.
It's even down to the suicide rates. So suicide rates, especially in young men who get cancer, are something like 300 times that of the normal population. And young men tend to be the worst for suicide anyway. So that self-confidence sort of perpetuates itself into that, or perpetuates itself into that area as well. It's having the confidence to talk to people. It's having the confidence to to be able to be and to understand that this doesn't mean the end, and having the confidence to drive forward.
Yeah, well said.
I think it, it all does tie into the support structure that patients have. Ultimately, you can do Exacta, you could do Astron, you can do Foundation One, whatever, but who are you going to talk to about those results?
Yeah.
Who are you going to talk to? I get through about 70 patient queries and emails a day. I've got 20, 30 that have just built up, because they can't ask their own doctors. They can't ask their GP, or they feel they can't, that the services are stretched, or they don't have a great relationship with them. So there's a worry about a liver function, a worry about a bowel disturbance, worry about feeling unwell, my heart rate's off, my thing, so there's a massive need for that. So one thing is, of course, the confidence to self-advocate, but having someone that you can ask, discuss with in an unbrazen manner or a non-abrasive circumstance and situation. I'll have the odd consultant that will tell their patient, not me directly, will say to a patient, oh, there's a danger of becoming hypoglycemic with metformin. It's not even a side effect of metformin. There's a danger that celecoxib will cause horrendous bleeding. There's a danger that aspirin will do the same. There's a danger, and you think, really, whilst on a life-threatening chemotherapy, you're comparing metformin and maybe a low dose of a statin or whatever it might be, or mebendazole, just because you don't know what mebendazole is because you've never prescribed it in your life. I didn't know what it was until I got into metabolic medicine, but just as an example, right? So there's a lack of that wish or want, because the job as a doctor is you're a purveyor of a predefined protocol. That's your job, to put a smile on the face of being a cog in a public sector machine. No disrespect. And that's fine, because as you said, Travis, it's based on the highest caliber of data to date, but that's become something that they can hide behind. That is my job. It's safe, it's secure. I don't need to engage anything else. Call it conservative culture, call it what you want. So anything else is farcical, scam artistry, quackery. Even though information's at my fingertips and I could do an AI search or look up this and that, I'm not going to. I'm just going to fearmonger and say that's all a waste of time. There's no proof. And so the number of times I put a patient in the middle of it that has that information, they're either worried or they're, because they have no trust in their doctor, are happy to go against their wish. And that is not ideal. That is not ideal, but that's the problem. There's no support structure. A patient can't reach their consultant and have an engaged discussion with them. They're the good ones who might say professionally, I can't support this. It's not within my remit. Please send me a list of what you're considering. I will run it by the pharmacist, see what they have to say. And I think that's a very decent and very professional response, right? But those that go the other way, to the other extreme, they just sound foolish, but what can a patient in the middle do? So I think it's a real problem, but that's again tying down to, have a team around you. If you want to consider things, only do things when you're comfortable. Don't let emotions, try not to let emotions, it's very easy for me to say this, but try not to let emotions run your decisions. Factual, to the point, calm discussion with whoever it might be. And if it isn't for you, it isn't for you. You don't need to do anything you don't want to do. But this is meant to be a tool of empowerment, all of this stuff, all these discussions that we're having, all of these avenues.
Yeah, that risk reward calculus is with the terminal illness goes through a different lens, right? I mean, walking across the street carries risk. And so when you define it in that context through a patient's lens, it's entirely different. Yeah. Well, gentlemen, this has been absolutely fascinating. We have roughly 5 minutes left. So let's hear, Dale, how you want to change the world. Obviously, you're starting new endeavors. And what's the plan? What are your goals now?
So there's a few of them at the moment. I think starting with the most obvious one, because Harry's on the call too, is I'm actually in the process of starting an integrative health clinic focused on oncology specifically, for which Harry has agreed to come and assist me with and be part of the medical team, or run the medical team for us. And the idea of the clinic will be in order to try to give as many people access to off-label drugs, to integrative health practices, to complementary therapies, and to other things that they can't find within the standard of care that can, will, and do complement it and give people better survival rates. Atop that, there is also the Beyond the Standard charity, which myself and Jane McClelland, the author, have launched. And the aim of that is to educate within the UK standard of care initially, and then we want to branch out globally as well. And we would like to try and use that to essentially lobby for change within the standard of care practices, especially around the use of metabolic therapies and off-label drugs. And then atop that, I've also got a blog, and I've also just bought a health business. So I'm trying to make as many different pieces of therapies available to cancer patients for as cheap as possible. And I'm also then writing about it in the blog so that people understand and know where these things fit in.
Where can people find your blog?
So my blog is thelifeorganic.com.
Wonderful. And Dr. Kuhan, where can people find out more about you and what's exciting?
Thanks, Travis. Yeah, so I wish I went first, Dale. So first of all, hats off to Dale. That's amazing, everything, and it's an honor to be involved with with some of these ideas and dreams, and I'll do my best to make it come to fruition, of course. So I work. So my clinic is called Lucio Health, and we have a website, luciohealth.com. Travis, I think I recently published a book with Amanda King. So we've grown, into each other's lives over the past few years, and it was just a collab that was waiting to happen. I've learned immense amounts from her, and she's probably learned very little from me. But we wrote a book called Metabolic Drugs for Cancer, which is on Amazon at the moment. We released this just about 3 weeks ago. I want it to be the one of many endeavors. So I think, well, you probably know, Travis. I mean, with your bestseller, you get a bit obsessed over it. There was a kind of a high from doing so and having the opportunity to put thought into paper, into writing. A great learning experience for us both. And so we look to hopefully releasing a few more series with specific cancer types. But this was an introduction into repurposed medicines and a very up-to-date sort of body of work, quoting the most up-to-date research about some of the top off-label repurposed medicines around. So I very, very similarly to Dale, want to just bring this to the front line, essentially get this to the front line, do whatever it takes. Very excited about working with Astron and trying to get some publications out so we can get our foot into the door of the academic space to try and drive change in many different forums. So just trying to remain active, grow the profile, more collaborations, more social media, get the content out there, and do what we can to do this in the right way.
Wonderful. What's the title of the book, Harry?
Metabolic Drugs for Cancer.
On Amazon, I assume?
On Amazon.
Yeah. Okay. Wonderful, guys.
Great read, by the way.
I'm sorry, Dale?
It's a great read, by the way.
I've yet to read it, but I've gotten reports already from a few colleagues that it was a wonderful book. Yeah. Well, thank you so much for your time, gentlemen. It was absolutely wonderful. And thank you, everybody, for attending. And I believe this will be recorded. So those that didn't get to attend live will be able to watch it later. And everybody have a wonderful week. And thank you again, gentlemen.
Thank you very much. All the best
Much
to
appreciated,
everyone.
guys.
Take care.
Have a good evening.